So I would like to shift the discussion a little bit from these different options to specifically talk about some of these drugs that can be given in twice a weekly dosing versus once a weekly dosing. So the guideline, the NCCN guideline, don't have dosing in the way that it's written. It just says that this regimen is supported by the guideline. But then there are references in the guideline, and some of the insurance companies, they like to read all those details. So if physicians use these combinations, but use, for example, weekly dosings, because there are studies that show that they could be similar to the twice weekly dosings, some insurance companies would say that's not what the guideline uses as a reference, so therefore it's denied. Yeah. So what's the answer for this?
So you'd like to use once weekly dosing at a lower cost compared to twice weekly dosing at a higher cost, or even if the cost is the same, you'd like to use.
The reason is that it's more feasible for the patient.
Sure. So most health plans agree to follow the NCCN guidelines, but most health plans also, and some by statute, state statute, say that if you can produce two peer-reviewed articles supporting the treatment regimen that you're recommending, that we have to follow that, and we'll do that. And I think in this circumstance, especially if the cost is lower and the evidence shows that the outcomes are comparable, we get better patient compliance with the regimen, better convenience, we'd be foolhardy not to follow that recommendation. But you're saying that some health plans won't allow you to do that because it's not in the NCCN guidelines, and I think that's why no two health plans are created equally. But I think over time, most people will migrate to the more patient-friendly, lower-cost regimens.
So we talked about transparency here for the purpose of cost. So couldn't you think of transparency also to apply, let's say that there is a drug that is a few percent better PFS twice a week compared to once a week. Mm-hmm. But for the patient, if it's twice a week, maybe it's not feasible. So there's not an option for the patient. If the patient chose the once a week, because that's really the only option for this individual patient, why shouldn't the patient be the one who makes that decision?
Well, let me tell you a secret. If you ask for twice a week but only give once a week, I'll never know it. And if you ask for, I can't remember the dosing for the twice a week carfilzomib, but if you give less than the prescribed dose, I'll never know it. So I think even if health plans aren't willing to cover those things, I think there's still some latitude for discretion in how you manage the patient. But now, on the other hand, if you ask for once a week and you give it twice a week, we'll figure that out real quick.
But this brings the flip side of it, that they don't have dose recommendation, because sometimes we want to use Kyprolis in a patient, in an older patient. If you go to the website of the carfilzomib, it'll say use carfilzomib with precaution in patient over the age of 75. Be extra cautious if the patient already has atrial fibrillation. So clinical trials were done in patients who did not have that, or if the blood pressure is not well controlled. Mm-hmm. You know, clinical trials were all done in a patient in a completely strict environment who met the criteria, et cetera, and you still had the toxicity, including cardiotoxicity. So my feeling is, the treating physician may choose to still use 27 milligram per meter square twice weekly rather than 36 milligram per meter square, which is what the KRD regimen was approved or whatever. So I have to say, and the another side is, I may start with the recommended dose and the toxicity. Clinical trials all give you dose reduction, you see? So you can't have dose as the criteria that would be policed by third-party payer or NCCN guidelines. So you can't put a dose in the NCCN guidelines.
The NCCN guideline does not have any dose.
Yeah, exactly. They should not. Because,
and they don't.
Yeah, exactly.
For these same reasons.
Exactly.
Yeah. So does the weekly dosing beyond the milligrams, the drug is charged by the milligrams. So one component is that, but then you have the once versus twice visits per week. Is that an important aspect for the payer also?
We don't have any limits on the number of visits that a patient can have with a provider.
But the patient has to come to the chemo suites 2 times a week?
And we don't have any limits on the number of infusions you can get. So it's really, we're focusing our attention on the high cost elements of care. And you're not one of them, it's the drugs.